We are now going to begin recording the webinar, and I just want to give a couple shout outs. First off, I want to mention that NCSD's annual meeting is going on. It is not too late to register. It goes on for the next 2 Tuesdays. And I'm just going to drop the link in the chat if you're interested in registering for that. And then I also want to just give a shout out to the National Network of Prevention Training Centers. The National Network of STD Clinical Prevention Training Centers is funded by the Centers for Disease Control and Prevention to assist clinicians in the United States with the skills, knowledge, and experience that they need to address and prevent STDs in their patients. Not only that, they've been an incredible partner to NCSD, sharing with our audiences great clinical knowledge and the training people need to provide great sexual health care. I'm really excited to introduce our speaker today, Dr. Christine Johnston. Dr. Johnston is an associate professor in the Division of Allergy and Infectious Diseases in the Department of Medicine at the University of Washington. She's an infectious diseases physician who performs clinical studies of herpes simplex virus, HSV, infection, focusing on the intersection between viral pathogenesis and host immune responses, with the ultimate goal of developing successful vaccines and medications to treat and prevent HSV infections. Dr. Johnston was an HSV subject matter expert for the 2021 CDC STI treatment guidelines. She's also the medical director of the University of Washington STD Prevention Training Center, which is part of the CDC-funded National Network of STD Clinical Prevention Training Centers. Today, Dr. Johnston will discuss updates to the management of herpes simplex virus and the 2021 CDC STI treatment guidelines. She'll be focusing on utilization of HSV serologic testing to diagnose patients with HSV2 infection. At the end of the session, participants are going to understand the epidemiology of genital herpes in the United States, understand when to perform HSV serologic testing for patients in STI clinics, and understand the limitations of HSV serologic testing and how to utilize two-step testing to improve diagnostic accuracy. This is a great presentation. It looks like it's going to be very engaging, so please hold on to your Zoom screens as we move through some really great activities during the course of this presentation. And without further ado, I'm going to give it to our speaker, Dr. Johnston. Please take it away.
Great, thanks, Michael, and thanks to NCSD for providing a forum for this important topic. I'm really happy to be here today, happy to see in the chat people really calling in from all over the country and from all over the world as well. I did see one from Kenya, so welcome to everyone. My goal today is to provide you some information and then which will take about, I'm hoping about 45 minutes, and then have some time for discussion at the end for questions and comments and really just a robust discussion with this group. I'm going to go ahead and share my screen. Maybe. Okay, and can you see the slideshow now? Michael, does that look good with the slideshow?
You're good to go.
Okay, perfect. Great. So these are my disclosures and funding. You can see my disclosures here. I am an affiliate of the Department of Lab Medicine at the University of Washington, which is the provider of the University of Washington Western Blot Test. And I do receive funding, as mentioned, from the NNPTC, the National Network of STD Clinical Prevention Training Centers, which is CDC funded. And I did receive some CDC funding to work on the 2021 guidelines as well. Well, as we're all aware, the 2021 guidelines were released in July, detailing a lot of new information about STI treatment. And again, my goal today is to delve into the herpes simplex virus section of the guidelines. Well, before we start talking about how to diagnose and manage genital herpes, let's think about, again, the enormous impact this infection has. Worldwide, it is the leading cause of genital ulcer disease, and you can see some just very severe ulcerations in one case here, and then also mild manifestations other times, but which can cause significant morbidity. And in its most morbid and mortal form, herpes can cause neonatal infection, which can really produce long-term effects on the development of children who have this, and is still associated with a high mortality rate, even with antiviral medicine. Either genital HSV1 or neonatal herpes can be caused by herpes simplex virus type 1 or type 2. Both of these viruses are acquired during genital to genital or oral to genital sexual contact, and transmission and acquisition is often subclinical or asymptomatic. And so people may not be aware that they have the infection. They may not be aware that they're at risk of transmitting the infection, and they may not be aware that they've acquired the infection. There are some serious healthcare disparities in seroprevalence, which I'll show again in a moment, but women are more affected than men, and the seroprevalence is higher in racial minority populations than in white populations in the United States. So we really need to address these, this infection to really correct these health disparities. HSV2 also increases the risk of HIV acquisition by 2 to 3-fold. So it's an important risk factor for acquiring HIV. And of course, because it is a lifelong infection, it's chronic, it can affect people across the lifespan and can have serious consequences for people's sexual health throughout their life. In the United States, the genital herpes epi, it's really staggering. And this was a nice review that was just published this year in STD, a nice analysis, estimating that there are about 18.6 million prevalent infections of HSV2 in 2018. Two-thirds of the infections are estimated to be in 35 to 49-year-olds, and the seroprevalence does increase throughout life as people are experiencing perhaps more sexual partners, more sexual activity. And women also account for about 65% of the prevalent infections. In terms of the new infections, there's about 500,000 new infections of HSV2 every year. And really, we're seeing equal number of infections in men and women who are acquiring HSV2. These estimates do not include genital HSV1, which we know is an increasing cause of genital herpes and would likely add millions of prevalent infections if we could accurately measure that. Now, when we look over time for HSV seroprevalence in the United States, we are seeing some improvements in terms of declining seroprevalence. What you're seeing here is over time on the x-axis, so from the year 2000 to 2015, and then the proportion of the population infected on the y-axis. In red, you see HSV1, and in black, HSV2. So in both men and women, we're seeing a decline in HSV1 seroprevalence, so that our overall seroprevalence in the United States for HSV1 is now about 48%, about half of the population has HSV1. And we're also seeing some decline in HSV2 seroprevalence, especially among women, and now have about 12% of the total population aged 18 to 49 infected with HSV2. Now, I've already mentioned that many people are unaware of their infection, and actually it's estimated that 80% of people do not know that they have HSV2 infection. Those that have recognized symptomatic infection are really the minority, only about 20%. Most people actually fall into this undiagnosed category. So they may have mild symptoms, they may have unrecognized symptoms that they never receive a diagnosis. But in fact, when they are informed about what genital herpes symptoms are, they may then recognize like, oh yes, I do have genital herpes outbreaks. I do have this infection. It seems that about 20% of people truly are asymptomatic. So some people may never have an outbreak or an infection that they're aware of. And that's an important group as well. So why should we diagnose genital herpes, and how do we control this infection? Well, the diagnosis, clearly there's a high prevalence, even for HSV2, about 1 in 7 people in the United States has this. Most people who have HSV2 are in fact symptomatic, but they don't recognize their symptoms because they may be mild and may just be unrecognized, but they actually do have symptoms. We know that transmission occurs from undiagnosed people. So if you don't know that you have an infection, you can't take steps to prevent transmission to other people. And there can also be issues for pregnancy management, both for people who are pregnant as well as their sexual partners. Another important issue that we don't often talk about is that patients want to know their status. People who are sexually active actually want to have this information so that they can take steps to protect themselves and their partners as well. And so it's something, often a disconnect, I think, between providers who may not want to test for this and patients who really do want to know. So to diagnose genital herpes, and this is new information in the guidelines, in the presence of a lesion, we would use a virologic test to make a diagnosis. And this involves actually swabbing a lesion for HSV PCR or culture. Now, currently, HSV PCR is recommended as the preferred test in the 2021 guidelines, and it is now quite widely available. There are several FDA-approved HSV PCR tests available. HSV culture may still have its place to specifically diagnose acyclovir-resistant HSV, and it may still, in some places, be the only virologic test available. In the absence of a lesion, we need to do a serologic test. We need to look for antibodies in the blood to make the diagnosis. I'm going to show some data soon to show you that Igm testing is not useful. It still is available in many settings, but really is not a helpful test. And unlike other infections where we can actually tell if people have recently acquired the infection based on the Igm testing, we actually can't do that for HSV. So it's not helpful to show that someone has recently acquired the infection. We also have HSV, IgG type specific serologic testing. There are several platforms available, and this can be used as a diagnostic test to diagnose people with symptoms of genital herpes. It can also be used as a screening test for people who may want to know their status. And I'll talk more about the differences between those and when you may want to use one or the other. There's confirmatory testing that's available, a test called the BioKit or the Western blot. And then I want to talk through some of the complexities of testing. Now, we do have some polling questions. I want to just get a sense from the crowd. What does your clinic use for a virologic diagnosis of HSV? Are you using culture, PCR? I didn't talk about direct fluorescence antigen. This is a test that's no longer recommended due to poor sensitivity, but is still, I think, available in some settings. Is testing not available or you're not sure? So I see people are busily voting, which is wonderful. We'll give a couple more minutes here. Great. I'm going to end the poll in 5 seconds. Okay, great. I hope you can also see the polling results. And this is actually very exciting for me to see that about half of people do have access to PCR. That I've been asking this question for many years now, and that has steadily increased. In many settings, about a quarter of people actually are still using culture for diagnosis of HSV. Culture is still an excellent method, but it is less sensitive than PCR. So PCR, especially for low quantity lesions, PCR is more likely to give you an accurate diagnosis. No one's using the DFA anymore, so that's wonderful as well. Great. All right, let's see if I can go back to, okay, so another polling question for you. What does your clinic use for serologic testing for HSV? Are you using IgM? Are you using an IgG enzyme immunoassay or chemiluminescence immunoassay? Do you have Western blot, something else? Is it not available at all, or are you unsure of what's available? And obviously no right or wrong answer here, just trying to get a sense of what people are using. So I'm going to let people keep voting. Thank you everyone for voting. This is exciting to see. All right, and I'm going to give 5 more seconds, get the last minute votes in. Okay, great. So you can see here that most people actually are using the IgG, EIA, or CLIA, and very few are using the IgM testing now. Very few have access to the Western blot, and unfortunately, a high proportion of people, about 1/3, don't have access to serologic testing. So that is definitely concerning. Oh, and sorry, I hope you've been able to see that, but here are the results of the poll. Great, thank you everyone for voting. So I want to just go over the data for the IgM testing and really emphasize that this is an inaccurate test. It's a waste of money and we really shouldn't be using it. It's not recommended in the 2021 guidelines due to poor sensitivity and specificity. Also importantly, it does not differentiate between HSV1 and HSV2. There was a really nice study done out of Mayo Clinical Labs, just looking at IgM testing. And they had looked over, this is a reference lab, so they do receive lab testing from around the country. During a 3-month time frame, they had 22,000 HSV tests ordered, and 20% of these were IgM only tests, and about IgM serologic testing was included in over half of all of the HSV related testing. Oops. And what they found was when the tests, if you look at the panel, the IgM alone testing, only 2.3% of those were positive. And when they looked at the combined panel, still a very small proportion overall of IgM tests that were positive. What's more is they didn't agree with IgG positivities. So they really we're having a discordant result. And of the 171 times when IgM and HSV PCR were ordered, which may indicate potentially a recent infection or definitely a recent reactivation, only 1.2% were positive by IgM alone. Most were positive only by the RT-PCR, and about 5% were positive for both. So really the IgM testing was not adding anything in the study and was potentially only causing confusion and wasting money. And so as a result of this, at Mayo Clinical Labs, they actually decided to stop providing this testing altogether, which I think was really helpful just to improve our diagnostic stewardship. And I know that this IgM testing is still available at many other labs. And I just want to, again, emphasize that we really discourage ordering it because of these testing issues. Now, in the guidelines, the new section of the guidelines, there are specific situations when people may want to consider testing for HSV antibodies. This would happen in cases of people who have recurrent or atypical genital symptoms, but have not had a positive virologic test to confirm that it's genital herpes. So people who have either not been tested or who've had a negative test result, those who've had a clinical diagnosis of genital herpes without a laboratory confirmation. So maybe someone goes to their provider and is told, oh, this looks like genital herpes, we're not going to test for it. They really don't then know for certain if they've had genital herpes. And also for people who've had a partner with known genital herpes, just because we do know that the transmission can occur, this would be someone who would be higher risk for, at least we know they've likely been exposed to genital herpes and maybe at higher risk for acquisition. And then there's also among people who may be at higher risk for infection based on sexual practices. People who are at higher risk would potentially be those presenting for an STI evaluation. We do know that the seroprevalence increases as the number of sexual partners increases. So, you could consider it as that number gets higher. People with 10 or more lifetime sexual partners may be at higher risk to have the infection. And we do know that the seroprevalence is also higher in people with HIV infection as compared to those without. And in these people, you may want to consider either screening for symptoms of genital herpes, really seeing if they do have recurrent genital ulcers or self-limited genital sores, and considering the serologic screening if they do have those symptoms, which would push them up to this category, or having a conversation about whether screening should be performed in that case. The U.S. Preventive Services Task Force has looked at this issue of screening in asymptomatic adolescents and adults, and they really have given this a grade D because of a lack of evidence that it's helpful and some suggestion that it could be harmful. And I'll talk more about that in a minute as well. So that's where these are the populations to consider testing for HSV antibodies to diagnose genital herpes. When we do think about the serologic testing, what are we looking for? We're looking for antibodies, and the antibodies are reacting to these glycoprotein spikes in the viral envelope and the viral that stick out and generate strong antibody responses. Most of the commercially available tests are based on the glycoprotein G, and this is an antibody that does differentiate between HSV1 and HSV2. So they can differentiate, although there may be some overlap, which I'll talk about in a minute. So this is what is used for the EIA and also the CLIA tests, as well as some of the immunoblot tests. The Western blot test is another way to test that looks for multiple antibodies to these glycoproteins. And that is a way that that is the reason that it's the gold standard. It's not looking just for one antibody, but for multiple different glycoprotein antibodies. And these tests can differentiate between HSV1 and HSV2, which is very important when making a diagnosis of genital herpes. So I want to spend some time talking about the EIA and CLIA testing, since that's what most people are using in clinical practice. And these tests provide an index value. The index value is an indication of the strength of the response, the antibody response to HSV IgG, but it's really not necessarily associated with the severity of infection. The way these tests have been approved, an index value of 0.9 is considered negative, 0.9 to 1.1 is considered indeterminate, and greater than 1.1 is considered positive. So when people are receiving their test results or providers are receiving the test result, anything greater than 1.1 will be, we'll say, positive for HSV1 or HSV2 antibodies. This has been a longstanding known issue that actually these tests don't perform as well as we would like. So this is a very important retrospective study that was done among 864 patients who were seen at the Westover Heights Clinic with Terry Warren, who I know is on the call. These people had an EIA followed by a Western blot. And several issues were identified. One with the Herpes Select test was that the HSV1 sensitivity was low. So only about 70% sensitive. It was missing a lot of people who had HSV1 infection, but it was very specific, so very few false positives. On the other hand, with HSV2, it had very few false negative tests, but a high number of false positive tests, so only 57% specific. And breaking it down further, they looked at the index value and the specificity. And what you can see in this table is that if your index value is 1.1 to 2.9, which again, remember, is considered to be a positive test, it's only about 40% specificity. So more than half of those results actually do not confirm to be positive by the Western blot. It does get better when you have a higher index value of 3 or greater, but still is only a 78% or 79% specificity. And when you're diagnosing someone with a chronic infection that's going to potentially, for many people, it does impact their sexual health throughout the rest of their life, you want to be sure that you're giving them an accurate diagnosis. So they found also that for HSV2, if HSV1 positivity was there as well, if they were HSV1 positive as well, there was also some issues with the specificity being lower. So false positives more likely at lower index values and in people with HSV1 infection. So there were some limitations of the study, potentially selection bias. These patients were self-referred and highly motivated to test, but it is consistent with several other published studies and is known. So this is just really underscoring that there are some real issues with the tests that we do have available. So based on that, the guidelines really want to call out this issue of specificity with HSV2 and recommend confirmatory testing if HSV serology is performed. The way we're doing that is similar to the way syphilis testing is done, where you don't depend on just one test to make a diagnosis of syphilis. You depend on 2 tests. And this is a similar issue here. We wanted to have confirmatory testing. So what's recommended is, given the poor specificity of the EIA assays with low index values, serologic diagnosis of HSV2 really requires confirmation using a test that has a different HSV2 antigen. And the tests that are known to improve the test performance of Herpes Select are either using a BioKit or a Western blot. In addition, serologic testing 12 weeks after suspected recent acquisition is recommended. And again, Igm testing is not recommended. In many places, we do realize that confirmatory tests may be difficult to come by, may be unavailable. And in those cases, it's a good chance to have an informed discussion with patients to counsel them about the limitations of testing before their tests are performed, so that you have a plan in place about whether confirmatory testing can be done. Health providers should also be aware that the false positives can occur. I just want to mention that that study was done based on Herpes Select, which you can see here is the company is called Focus, was approved in 2007. Many other tests have been approved since looking for HSV antibodies, but my understanding is that they were all, many of them were approved comparing to the Herpes Select. So we are concerned that many of these other tests actually have these issues with specificity as well, although they haven't been as well studied. And this just demonstrates one issue, a recent study that was performed showing that the Liaison, which is a CLIA test, actually also has a high proportion of false positives, even with high index values. So, this is really somewhat of an unknown area, but another concerning piece of HSV serologic testing. Okay, I want to do a couple of cases now to demonstrate some of the issues here. I'm seeing a lot of activity in the chat. Maybe I'll pause just for a moment to see if there are any questions that we should address right now, Michael. Otherwise, we can wait till the end.
I think we can work through to the end if that works for you. I don't want people to miss out on the case studies, but right now we have an amount that we can definitely cover. Okay, perfect. I'll just keep plowing through. So here we have a patient who many of you may see in your practice. A pretty typical patient, 32-year-old cisgender woman, a history of 8 lifetime male sex partners, coming in complaining of occasional itching in the genital area, seems to happen 2 to 4 times a year, can be self-limited. The symptoms usually resolve in 3 days. And actually, when she made the appointment, she had symptoms, but now they've resolved. She has self-treated for vaginal candidiasis when this occurs. And during one episode, she was seen by a provider. She's told that she had a sore, looked like it could be a resolving genital herpes, but then her culture was negative. And she doesn't have, as I mentioned, her symptoms have resolved. Her genital exam is normal. So should this person be tested for HSV2? And I'm going to just go ahead and take a poll and see what you think. Should this person be tested for HSV? Yes, no, maybe. So we'll give a few minutes for the polling to come in. Great, lots of voting going on, which I love. All right, I'm going to give 5 more seconds for the polling. Okay, great. So 70% think yes, this person should be tested for HSV. 14% say no, and then 16% say maybe. So I myself would test this person for HSV infection using the serologic test based on, and I think she meets criteria based on the CDC guidelines. She does have occasional itching with self-limited symptoms, which could be consistent with genital herpes. And she also has a clinical diagnosis of genital herpes, but it's not confirmed. So now I want to know how will you test her? What testing will you use to diagnose her with genital herpes? Will you use a genital swab for HSV PCR, a genital swab for culture, IgM serology, type specific HSV IgG with confirmatory testing, or an HSV PCR from the blood? What will people use? Great, testing is coming in, or answers are coming in. Thank you for voting. I'm going to give another moment. Great, I'm going to end the polling. And wonderful, so this is great to see how people would be testing. So most people would use HSV type-specific IgG with confirmatory testing if needed. And that is also likely what I would use as well. I think it's important to go over when to do genital swabs. So the genital swab testing for either HSV PCR or culture in the absence of a lesion is really going to, it's not an effective test, high risk of a false negative, because we know that HSV shedding is intermittent, and we know that people may not be shedding in the absence of a lesion, and so they may in fact be infected, but you're not capturing it. So I really would only reserve genital swabs for a time when there is an active lesion present. Another interesting idea is doing HSV PCR of the blood.
And remember that HSV PCR is really detecting the active virus. It's detecting the virus, not the antibody, not the immune response to the virus. And we know that HSV in the blood is very uncommon. Even among primary infection, when people are just acquiring HSV, it's only about a quarter would have HSV detected in the blood. It's really a test that I only use if I'm worried about someone having disseminated HSV infection with hepatitis and someone who's very, very ill. So again, HSV PCR in the blood, it's very rarely going to be positive in the blood, but doesn't necessarily mean that you don't have the infection. So that's really one that I wouldn't typically use. Great. And if there are any questions about that, we can talk more in the chat at the end as well. Okay, so let's think about, I would put that first case as diagnosing HSV because it's someone who had a typical history that could have been consistent with genital herpes, also had a sexual history and potential risk for having acquired HSV2 in the past. In this case, it's a case of screening, also a patient that we see many times who wants to know their status. It's a 25-year-old cisgender man, anxious that he has genital herpes. He has 2 lifetime cisgender female sex partners, always uses condoms, and no history of genital symptoms, no history of any STI. And he has regularly tested for STIs. So should this person be tested for HSV2? So let's do another polling question, please. I think it's polling question 3 again. Great. So who would test this person for HSV, for HSV2 infection? All right, the polling is going on. And I am going to go ahead and 5 more seconds and I'll end the polling. Great. So wonderful. I love these answers. So about 2/3 of people say no. About 20% say maybe, which I think is a great answer, and maybe more discussion with the patient, understanding why the testing is desired, and 12% would say yes, which is a patient-centered response, I would say, because he really wants to be tested. Great. So again, I just wanted to show this U.S. Preventive Services Task Force recommendation against screening among asymptomatic adolescents and adults. It actually gets a grade D, their worst grade. And because of the limitations we have with the serologic tests, I actually do agree with this recommendation for people who you have a low pretest probability, such as this person who doesn't have any history of genital symptoms, doesn't have any prior history of STIs, and doesn't have a high number of sexual partners. So ideally, if we had outstanding testing that was affordable, I would be more excited to test, to let everyone know their status. But I think given those limitations that I've discussed, I agree with this. So of course, in this case, he was tested anyway, and actually was sent home with a diagnosis of HSV2. He was tested by his primary care provider. And the type-specific HSV2 ELISA that you get had an index value of 1.5. So if you recall, index value of 1, anything greater than 1.1 is positive, but under 3 has a high risk or poor specificity, high risk of false positives. So in this case, oh shoot. In this case, I just wanted, I've heard from many people similar to this patient who don't get confirmatory testing and actually go for weeks, months, or years with thinking that they have genital herpes, It does lead to enormous stress for some people. These couple of articles that were written in the last couple of years really highlight some of the patient issues that occur when you don't have accurate testing. And it is, I think it does really lead to further stigma of herpes. I do want to point out that there is the impact of not testing as well, where people aren't aware of their status, can't take the steps to protect themselves, may have increased risk of transmission to partners, and really just have a lack of self-efficacy if they don't know their status and can't take the steps that they want to take to preserve their sexual health. So in this case of this patient, a Western blot actually was performed, positive for HSV1 antibody, negative for HSV2 antibody. And so this is how two-step testing should go in practice. The index value of less than 3 reflexes to a secondary confirmatory test. And before even giving the patient the diagnosis, ideally, you would do the confirmatory testing and know whether or not the infection was truly there. I do acknowledge there are several issues with this strategy, mainly in the availability of these tests and the high need of providers to be aware of this, because labs are not necessarily reflexively doing the confirmatory testing or attaching information about confirmatory testing to their diagnostic paragraphs. The Western blot is not always covered by insurance and more often is not covered by insurance. And that is why I think it's really important to have these informed conversations with patients, discuss these issues prior to decision-making, prior to testing, so that you can use shared decision-making about whether testing should or should not be performed. So what about HSV1 serologic testing? We do know, I already showed at the beginning, HSV1 infection is highly prevalent. We can't, unfortunately, with the serologic testing, differentiate between genital and oral HSV1 infection. That is just a limitation. And we do know that most people are likely to have oral HSV1 infection. I showed the data about the poor sensitivity with our commercially available tests. And really, I think in general is HSV1 serologic testing is rarely useful in the sexual health setting and not routinely recommended. I do want to point out that there are opportunities to report to the FDA about these testing issues. Ultimately, we really would like to have better testing so that we don't have to face these issues. It would be better for providers and patients. And here's a link to how to report. And I just want to call out a Herpes Cure Advocacy Group, which the link is here. They are a newer group on the scene that are really advocating and raising these issues of testing problems, as well as trying to advocate for better treatments for HSV. So very quickly, I want to talk about other guideline changes. We do have new sections in the guidelines for HSV1 and HSV2 counseling, as well as discussion about the rare but significant complication of HSV hepatitis. For treatment, I can say, sadly, we don't have new therapies, we don't have new vaccines. There is one new recommendation among people living with HIV. If you're starting ART and they have a low CD4 count, consider suppressive acyclovir in that setting, because we know that there is a risk of immune reconstitution inflammatory syndrome and increased genital herpes outbreaks after starting therapy. Again, here's just a slide showing the unfortunate state of genital herpes treatments. We have 3 drugs available. They were available in 2021, available in 2015, available really for the last 25 years. So we're just, hoping to have some advancement in our treatments, but right now we don't have anything new. This is just a summary of our treatments. They haven't changed, except to remove some inconvenient dosing schedules that patients really can't use anyway. I won't go over that in detail. And then I put in here the counseling. I'm not going to go over this in detail. Counseling for genital herpes, it does take a long time. It is a complex infection, but there are some high points that you can highlight with your patients. And we tried to split it apart by pointing out some different issues if people are symptomatic, if they're asymptomatic with HSV2, or if they have HSV1. So I'm going to conclude by just saying it is really imperative to use accurate diagnostics when making a diagnosis of a chronic viral STI. Ideally, we would have better testing. We know that we need improved serologic tests for HSV1 and HSV2 and a better widespread availability to perform the two-step testing, but we do have knowledge about the pitfalls of serologic testing. We can talk to patients, especially those who are really want to have testing performed, about the limitations of our testing so they know what they're getting into. And we do have some availability of the two-step testing. So I'm going to stop there. At the end of my slides, which I think will be available somewhere, I do have some additional resources about the National STD curriculum, which I encourage everyone to check out. The clinical consultation network through the PTC, where you can submit questions with difficult cases and you'll have an expert reply. And then we also have extragenital testing resources if people desire these. So I'll stop there and take any questions. And actually, I may call on Terry Warren, maybe to start the conversation, because I know, Terry, you had some thoughts about your experience with even using some of the confirmatory testing.
I will say our only way to communicate with Terry is via the Q&A. So folks, if you're in the chat, please do move over to the Q&A with your questions. That's how we'll be sure we get to you. And thank you so much, Dr. Johnston. That was a phenomenal presentation. I know I learned a ton. And I do want to second your shout out to the folks at Herpes Advocacy, because they were really the impetus for us scheduling this webinar, and they are really a driving force behind keeping the conversation about herpes active. So with that, let's dive into some of these questions we have in the Q&A. Our first one is, it automatically goes down right when someone posts one, so it moved. Okay. How is the evidence determined that approximately 20% of people are asymptomatic? Have there been seroprevalence studies of general populations?
Yeah, that's a great question. And there have been seroprevalence studies, and Haynes is our one in the US where we can test for the seroprevalence. And that's actually where the figure comes from, that 80% of people who have HSV2 haven't been diagnosed. But really the proportion of people who are asymptomatic comes from clinical studies of people who are seropositive, and then following people over time, educating them about the signs and symptoms of herpes, and then following them and determining that over time they really don't seem to have any symptoms.
Do multiple indeterminate tests equal a negative or a positive, or is it recommended that patients come back at a later time to test again until you get a determinate result?
That's a great question as well. And I know that in the community, some patients do repeated testing, and it's always very stressful when you have an indeterminate test, both for patients and providers. I would say, I'd worry with the indeterminate tests that they're also running into some of the same specificity issues that are seen even with a positive test. So rather than continuing to repeat that testing over time, I would prefer to do a definitive test like a Western blot. I will say that, the one caveat to that is if someone may have had a recent acquisition, if you're concerned about a recent acquisition, it can take up to 12 weeks to seroconvert. So that may be a single, if you have that exposure history, a single time to do a repeat testing, and then doing the sero, doing a different test, potentially Western blot.
Can you speak to more details about the BioKit? Where is this available? I understand that perhaps only one lab in the US has access to the Western blot. and that would be UW according to this questionnaire.
Yeah, and that is correct. And right now the Western blot is conducted at University of Washington. It's an old and clunky test. That's how we previously confirmed HIV diagnoses, and they have moved on from that to find other ways to confirm testing. The BioKit test is more of a point of care test. I know that some labs are using it for confirmation, and I know that it previously was available, but I have to confess I recently looked myself as well, and with the pandemic I haven't been able to figure out how to get it right now, and I'm still trying to look into that. So if I can figure out, and again, I don't know if Terry may have a comment. I don't know if you can make her a co-host, but yeah, anyway.
I can see about that. Yeah, we can definitely look into that.
I know Terry's commenting that LabCorp and Quest are not reflexing to the Western blot. Some of them have do reflex to BioKit, so it is available at some labs, but which one, for these large labs, I would say we don't know for sure.
Remind me, is it Terry Griffin or Terry Warren?
Sorry, Terry Warren.
Okay, do we just have two Terrys on the call? Terry, welcome to the panel.
Yes.
I just promoted Terry to panelist, so we should have. In the meantime, I do have another question. Should there be an automatic reflex at labs if a Herpes Select test result with an index value less than 3 is automatically reflexed to BioKit or UW Western blot? I hope I asked that question correctly.
Yeah, no, I think you did, and I think that would really be wonderful. That would be the key, because I think it's providers, to expect all providers to know about these complexities of testing is really ambitious, and so ideally at the lab level there would be an automatic reflexive testing, similar to the way that syphilis testing is done.
Hi Terry, thanks for joining us on the fly.
You bet.
Do you want to add anything?
Can you hear me?
Yeah,
Yes.
We can hear you now, Terry. Hi.
Hi. So right now, Westover Heights Clinic physical being is closed, but I do telehealth, and I order about 60 Western blots a month for patients. And my experience has been, I have 33 patients now who are positive on the LabCorp supplemental test, which is a BioKit, who are negative on Western blot. So I would not assume that those supplemental tests are correct. I think they're overreading the BioKit, and it's tricky. It's just a little pink dot. And if there's any pink, I think they're overcalling those positives. Also, for the Quest IgG test, without any confirmatory testing, the false positive rate in my experience between 1.1 and 3.5 is about 75% false positive on their current test. You can ask for an inhibition assay through the Quest testing system, and that does increase the accuracy of the test. But with the IgG test alone, I think it's not good at all.
So I just want to add in, I see a bunch of questions in the chat about posting slides. So Dr. Johnston, as long as it's okay with you, we will post the slides. There'll also be a recording made available if you want to watch the lovely show. I do want to get back to the questions. I just want to make sure we put that out there, that this will all be available for reference. We have another question about perinatal prophylaxis. So is that recommended for those with HSV2 positivity but no history of symptoms, or only for those with prior symptoms? And what about for those with prior HSV1 genital herpes diagnosed by PCR or with clinical findings and only HSV1 antibody positive? That was a long question.
That was a great question. So the complexities of treating people who are pregnant to prevent shedding at the time of delivery. So right now, ACOG and others do not recommend testing pregnant people for HSV antibodies. For people who are known HSV antibody positive, specifically HSV2 antibody positive, or for those who have a history of any genital herpes, I would say 1 or 2, I would do prophylaxis. That prophylaxis is acyclovir, starting at week 36 and to delivery. Interestingly, that has been shown to decrease shedding of HSV at the time of delivery. The studies are, we can't, it's a rare outcome. So it's very hard to do a study that actually would show that we prevent neonatal herpes. I will say that there have been reports of breakthrough transmissions, but it is our best tool right now to decrease shedding, at least at the time of delivery.
So we do have a lot more questions. We have like 25 more. And so given that we aren't going to get to all of them, I do also want to give you a chance to share, is there a way for our attendees to get in touch with either you or somebody at the PTCs as a resource for clinical knowledge around HSV?
Yes, I am definitely always happy to take questions, and my email is at the end of the chat, the slide presentation. I'll put it in the chat as well. I can go through and answer these questions, and maybe we can post them with the talk rather than trying to answer every person individually and send it back to you. We'll make the answers available to the group.
That would be so great.
Yeah, I would say for clinical questions that arise, specific patient care questions, always do the CCN, STD CCN, and yeah, those are the resources available. So I guess, Terry, I'll put you out there too at the Westover. Maybe you can put the your website in the chat as well, because Terry single-handedly sees many patients with questions and concerns about herpes all over the country. So
great presentation.
Excellent. Oh, sorry, go ahead.
I just said great presentation, Christine. I'm a fan.
We do have one really great question up next that I would love to spend some time talking about. And that was just, can you review how you typically disclose serologic testing results to a patient?
Yeah, I think that's a great question. And, it is a diagnosis that can be very difficult for people to have. It is a moment to, really just be respectful and, of course, try to give information about the diagnosis, which I think immediately destigmatizes it. So, when you're telling someone that they have a diagnosis of genital herpes, I do like to emphasize that this is actually a common infection. Many people do have this infection. It's not widely talked about. It is a stigmatized infection, but we can take strategies to take control of this infection for you. You can use condoms, you can use suppressive therapy to prevent transmission. But I think giving some space also for them to reflect on or kind of absorb is good. And then also realizing that, it's a hard infection because there are so many nuances about, reactivation and asymptomatic shedding, which actually COVID has made the conversation a lot easier in some ways, I think, because people understand these concepts now. But, just realizing that the information is very overwhelming, and it may take more than one conversation for people. Providing resources is also good. So I'd love to have a whole conversation about that with everyone on the call and hear some other people's strategies as well.
It sounds like there's room for a follow-up presentation then. I think that's definitely a good place to leave things off, is we're not done with the conversation, but thank you so much for sharing all this knowledge with us and really helping move the field forward. And Terry, thank you for hopping on the fly. I've never done this before, but I'm so impressed with all of our Zoom abilities, but especially mine, because usually those things don't go well for me. So thank you everyone for joining, and we'll leave things here, but do stay in touch and please look for these resources that'll be posted on NCSD's website. Thank you.